We move now to our guest speaker, who is from outside this jurisdiction, so is going to be able to give us a very different perspective. Our guest speaker is Dr. Matt Westmore, Director of Finance and Strategy at the National Institute for Health Research in the UK, and also involved in the evaluation, Trials and Studies Coordinating Centre. Matt is based at the University of Southampton, but I think if you look at his resume and summary of his biography, you'll see that he has been involved in this whole space of looking at needs-led prioritisation for quite a period of time in different ways and in different guises. So is very well positioned to actually speak to us now about the experience in the UK. I would just also note that one of the guiding sources for the briefing paper that you all got in advance, and which was on the tables today, was the James Lind Alliance, which is, I suppose, hosted part of that broader organisation that Matt is involved in. So he's going to talk to us a little bit about, I suppose, at a high level, strategic level approaches, but also then perhaps get a little bit more granular and delve a little bit deeper into, if you like, the process and some of the mechanics and some of the learnings from his experience on prioritisation of research questions. So without further ado, Matt, I'd like to invite you to address us. Thank you.
Thank you very much, Chair, and ladies and gentlemen, for the opportunity to talk to you today, but also to be involved in the discussion. It's been really interesting and useful from my perspective as well. You'll pick up I'm carrying a bit of a cold at the moment, so there's two ways this is going to go. Either I'm going to go very, very quiet and you aren't going to hear a thing, or I'm going to be shouting at you for the next 40 minutes. So please let me know if I'm doing either of those two things. So I'm going to talk to you about some experiences from the UK in this area of how do you prioritise the right research. But before I start, I guess just a quick question. Who here has heard of or is aware of the work of the National Institute for Health Research in the UK? Just a show of hands. Great. That's going to form the majority of what I'm going to talk about today. The way I'm going to structure it, though, is through, I'm going to walk through this excellent briefing paper that we've just heard about, and I'm going to talk about our experience under some of the headings which are outlined in the paper. I've got about 40 minutes and then half an hour of questions and answer at the end. But I'm going to pause as I go along under those sections. I'm going to group some of them together, but under those sections to take some questions and comments to try and break that up. So please feel free to contribute at those points or to stop me as we go along. First question, though, is who are we? So I've talked about the National Institute for Health Research. That is most of what we do. The part of the National Institute that I work for is the Evaluation, Trials and Studies Coordinating Centre, where we do a number of things. By far the largest, though, is we look after a number of the research funding programmes. We commit around about £140 million a year of research funding through those programmes. And each of those programmes has a priority setting process as part of it. So that's why I've been asked to talk to you today. But we also do a number of other things. You've heard that we're based at the University of Southampton, so we're on contract to the department to deliver the NIHR work, but we also do some work for the Welsh equivalent of the NIHR, the National Institute for Social Care Health Research, NISCA. We're just setting up some research funding programs for them. We do some other work for the NIHR around dissemination of research findings. So once we've prioritised the right research, it's been delivered, how do we give it some momentum to get it into the hearts and minds of those that we want to read this? And we do a number of other small pieces of consultancy work for the medical research charities. But by far the largest thing we do is to deliver the work on behalf of the NIHR. So I'm going to start with the first heading I picked out from the paper. What's the purpose of prioritising research questions in the first place? Why don't we just leave it to industry or leave it to the research community to decide on the priorities? We've heard a number of perspectives today, and I guess that's the first message, is that you've got to see this from different perspectives. This particular chart is from an analysis which is done every 5 years in the UK. We're just waiting for the next report, looking at the types of research which is funded by the public and charitable sector within the UK. Over on the left side, as you look at it, are research around the earlier phase research around underpinning, etiology. The pinch point, where it gets narrow, is prevention. And then we're into detection and diagnosis, treatment development, treatment evaluation, disease management and health services. So you can see that in the UK, the majority of funding, it's a relative scale, the majority of funding is in that underpinning and early phase research. What you'll see from the change in the colour, so the orange band on the left-hand side and the blue band, was the introduction of the National Institute for Health Research to try and rebalance some of that into more applied research, where previously it was felt that there was just a bit too much being dominated by the early phase research. It's important. We would be the first to defend the need of a system to fund research across all of these areas, but of course we need to get the balance right. We've heard a bit about that earlier. Actually, the founding principles of the NIHR go back to the 1980s, early 90s, a number of influential parliamentary reports which were bemoaning problems within the UK health research landscape at the time. That firstly, that industry in general were not addressing all of the research needs of the health service, and that the research which was going on within the National Health Service in the UK, whilst excellent in places, in general was not accountable, was not transparent, and was not of high enough quality to cause the change in service required. And so the NIHR was established precisely to start to readdress those kind of priorities. Another look at this is if you look at the way in which research is prioritised according to different sectors. On the right-hand side, as you look at it, we've got the registered commercial trials. Looks blue to me. Is it blue? Yeah, it looks blue to me. The bulk of these are, of course, in drugs, vaccines, and biologicals. The middle bar is registered non-commercial trials, so the kind of things that we would fund or charities would fund. And you can see a balance between the blue, which is drugs, the red, which in this particular analysis picked up things around radiotherapy, surgery, and preoperative interventions. It was about cancer care. And the first bar on the left-hand side, as you look at it, was some output from the James Linder lines, which we've just heard about. So this is where, and I'll talk more about this later, this is where you bring together in partnership clinicians, patients and carers, and by far the majority are in education and training. So the point here is that that depending on what perspective you ask, who you ask, you'll get a different set of priorities coming out. In some ways, no one particular priority is right. The point is you've got to consider the balance. Now, if you're like me, there'll be a steady stream of publications, reports, papers, literature that you'd want to keep up to date with, and we just can't. But every now and again, there's a paper that kind of grabs you by the scruff of the neck and says, "Stop whatever you're doing and read me." And one such publication was this by Ian Chalmers and Paul Glasziou. It was an editorial piece. It wasn't robust analysis. It's since been updated in 2014, and it had a big effect on us. The reason it did was because of this headline: 85% of health research funding is wasted avoidably. Now, as a research funder, that kind of thing makes you pay attention. We could have done one of three things here. We could have just ignored it, and it's a sad state of affairs in the rest of our lives that most published scientific literature has very little long-term impact. We could have picked it apart and gone on the defensive. The guys would be the first to admit that this was a back of an envelope estimation of the size of the issues. It would have been very easy to have discredited it. Or we could have embraced it and said, well, what does this teach us about what we're currently doing and what we can do better? And of course, I wouldn't be presenting today if we hadn't done the last of those. What it allowed us to do was to collect our thoughts and processes, the way in which we approached it in terms of a theory of change, if you like, in terms of a framework. What we couldn't have done, though, as a public funder, has gone around with the message that 85% of health research funding is wasted, But it's okay because the NIHR doesn't waste quite as much as perhaps others. Politically, that would have been a very difficult message to have carried. So we flipped it on its head, and we said, well, where are the areas that we add value and thereby reduce waste? Apart from that being politically a more comfortable message to take to the world, actually there's an important psychological trick. It means that we're going around looking for the positive things we're doing in the system to add value through our processes than just looking for areas of waste. I'm not going to go in detail, the slides will be circulated afterwards, but the two pillars which are particularly important to today are the first two, and that's that questions are relevant to the users of research. So that's about high priority questions being answered, that important outcomes of those questions are assessed, and this is in the language of Ian and Paul, that clinicians and patients are involved in setting research agendas. Now we fund a much more broad spectrum of research, so we would broaden that out, but the key point is that we involve the ultimate users and beneficiaries of that research in setting the research agenda. And the second one, which is important today, because it's an important part of the process, is that there is an appropriate research design, conduct and analysis. And there are some obvious things here around reducing bias and making sure that studies are well designed. But there are some less obvious things around how you involve these parts of the process in your assessment of which research to fund anyway. So I just wanted to pause there and ask if there are any questions or comments on this particular question around the purpose of prioritising research questions. Yes.
So did you find that you were delivering a lot more of your funding in a top-down mechanism as a result of the Chalmers paper? To very specific areas, very, very tightly defined, or this is the bottom-up versus top-down question.
So I'm going to talk in a minute about the balance of top-down and bottom-up for us. I don't. It didn't change. It didn't change our particular balance. What it did change is it caused us to look at the process by which we generated those top-down and bottom-up research priorities. So it caused us to. So, for example, one thing I'm going to come to later is that we now insist that there is a review of the literature done before we will embark on any new primary research. It's something that happened a lot before. It's certainly something that we did in terms of when we were advertising priorities, but it wasn't a major expectation we put on the research community.
As in systematic review
before primary research, yeah. So it doesn't have to be a systematic review in terms of a Cochrane review, but it has to be systematic enough to inform the funding decision. And that was an important change for us. Any other questions, comments before we move on? Yes.
Just very quickly, in putting together the framework you've just shown us, was that done consultatively as well? So very much from the off that you took that approach, even in defining the why.
Within the NIHR and the research community, yes. So particularly as well working with Ian and Paul and a much broader range of collaborators within the research community for some later work they did. I'd admit less so actually with the patient and public involvement, because it was more about our internal processes. Okay, I'll move on. So the next thing was to talk a little bit about challenges when setting priorities, and we've heard many. I'm not going to spend a lot of time on this because in effect the message is there are lots. This is by far the hardest thing that we do within my centre. I wanted to turn this on its head a bit. I'll read these out, so don't worry if you can't read them. These are some of the comments that we receive as to reasons why research isn't taken up in practice. So to come at it from the other end, say what are the barriers to research having an impact out there in terms of clinical care, services, public health, patients and the public. Because by setting priorities, we're trying to head off some of these future problems. So one of them we hear a lot is, it just asked the wrong question. Scientifically it's interesting, but it just asked the wrong question. It doesn't apply to our population. In other words, the population wasn't representative or it wasn't generalisable. It's years out of date. We've heard that research itself is a long-term game, and the implementation of research is equally long-term. It's not just about when you publish those results, it's the next 5 or 10 years it takes for that research to have an impact. The methods are rubbish. This is an important one. Some research, it's fairly easy to spot a good one and a bad one. So, a randomised controlled trial and evidence synthesis, they're very, I wouldn't say they're easy to design, but they're very straightforward to design once you've got the right experts around you. And there's a good infrastructure in the UK now, particularly around clinical trials units and review groups who are very expert at putting these in. Where it gets more challenging is some of the more mixed methods and qualitative research, where actually the quality of the methods are perhaps even more important, because as soon as you're going to put out something which might be sensitive or contentious, people don't like the answer, then one of the easiest things for them to do is start pick away at the methodology. And once they start to do that, then the research has lost its credibility. There's something about the way in which the research is published. You can't find what you need in the report. It's behind a paywall. It's much too long. These are some areas which I think we've still got work to do on. There's no research addressing my particular issue. Again, are they the right questions, or is it not generalisable? We hear a lot from the public health community now that we value different kinds of evidence. So we're producing research now for different types of evidence users. These are elected officials in local government. They're directors of public health now sitting in County Hall, not in the NHS. They are people who do not see themselves as public health decision makers, yet the decisions they make affect public health. They require different types of evidence and different methodologies. Studies don't agree. What do you do when you have differing outcomes? It wouldn't work here, it's unrealistic, impractical, or it's way too expensive to roll out at scale. These are the kind of issues that we're trying to address when we prioritise research. One of the challenges is what's your framework of asking questions? So one of the things that we do is we have standing committees of experts who we present ideas for research or proposals for research, and we ask them to consider the importance of that research in something broadly like a healthcare needs assessment framework. This one particularly is from Raftery. So we'll ask them, the key point is it's multidimensional. We'll ask them to consider the burden of disease, whether or not the health services can implement the research, and whether or not, of course, there's an evidence gap. Many of the things that get put to us, the research has been done. It's just that we don't know that we already know the answer. You might think we would then take an assessment of need as being some calculation of frequency times severity times impact times the evidence deficit. You have to discount that according to time, and that somehow would give you an idea of importance. But of course, it's not that straightforward. Slavishly following this kind of algorithm would mean that we would never fund any research in rare diseases or ultra-rare diseases, for example. But what we ask our panels and experts to do is to hold these kind of concepts in their mind, to make exceptions, to explore around the issues. We certainly don't go through a multi-criteria decision-making algorithm approach, but we do ask them to consider these kind of issues, but it is very challenging. So I'm just going to pause there for any questions or comments on challenges. Happy to move on? So grouping together a couple of the headings now. Characteristics of priority setting and priority setting processes. So getting into a bit more of the kind of practical side of things. We talked a minute ago about the difference between bottom-up and top-down processes. Broadly, the programs that we look after have three work streams. We have researcher-led or response mode. We refer to it as researcher-led. And I'll come to the reason for that in a minute. In essence, it's bottom-up. So researchers pitch for funding by setting out a potential research question for us to assess. The thing that's slightly different, though, I think, from many other funders, is that the first thing we do with that proposal is we put it to a committee and to a series of experts of the research users we're intending to influence with the outcome of this research before it gets to a conventional research funding panel to look at the scientific methodology. So if it's a clinical question, there'll be clinicians. If it's surgery, it'll be surgeons, surgical nurses, rehab professionals, allied professionals and the like. If it's public health, it will be third sector leaders, directors of public health, directors of child services in local authority. Only if it passes that test of importance does it get anywhere near the conventional academic research funding programme. At the other end, on the right-hand side, we have highly targeted commissioned calls. These are where we specify the question down to the population group, the intervention, the comparator we want it compared to, the outcomes we want it measured. We will even go further, the timeliness of the research, the policy context, if that's relevant. We'll put these out to the research community and we'll say we want someone to come along and do the research for that. And I'll talk a bit more about the process by which we do that. Now, I've said that's top-down because I was picking up on the language in your paper, because in a sense that's us setting the priority. But whether it's top-down or bottom-up really, I suppose, depends on whose bottom you're talking about. But the process by which we generate these priorities is not my team sitting in my centre deciding on what research to fund. It is through those consultation processes that we've heard a bit about earlier today, and I'm going to go into a bit more detail in a minute. What my team will do will be to collect these ideas from those external sources, to frame them as research questions, to do a bit of literature review to ensure that there are evidence gaps, to look at the burden of disease, and present this back out to those external and independent experts, committees and panels. And it's them who decide what we fund research in. So yes, it's top-down in a sense of it's set by the funder, but the processes by which we generate those questions are much more aligned to things like the James Lind Alliance than they are the research community setting them. Where we really are top-down, in a sense, is for our themed calls. There's one in the middle. And the reason why I've listed it as bottom-up is because whilst we set a very broad theme, it is broad. And therefore the specific questions that are asked and therefore answered in that research funding are specified by the research community. And here's, again, I'm going to circulate the slides afterwards, so it's really just to pick out a couple of these and not to read through in detail. What we do with themed calls is we set a very broad theme. And these do come from the top. Normally they'll come from the Chief Medical Officer. Clearly it will be around ministerial priorities as well through her. Strangely, in many of these areas, we don't actually expect to fund much research when we first issue the call, which is slightly bizarre from a research funder. But the point is there are areas where we know either there aren't the interventions to evaluate, so an example there might be antimicrobial resistance. Remember, again, we're an applied research funder, not basic research. Or there's a lacking in the research community, and that might apply to primary care interventions. Or the research is very difficult and therefore there are challenges in funding research around surgery. And what we're really trying to do is kick the system and say, look, there's going to be some important stuff that we're going to turn your head to today, but actually this is about the long tail. This isn't about the call we're making today, it's about the stuff that's going to be worked up this year, next year, and years into it. So these remain priorities for the NIHR. I wanted to go into a bit more detail about some of the processes. This is for our Health Technology Assessment Programme, the longest running of our programmes. Actually predates the NIHR. It's been running for over 20 years now, so it's the most mature and it's also the largest. The key thing from this slide is to note that we have a number of sources of potential priority which we collect from, and I'll go into a bit more detail in a minute about those. We have a number of processes within the programme, that's the middle collection of boxes. So we collecting the potential priorities we call identification. We then prioritise those through these external committees of experts, depending on what the clinical area is. Health technology assessments are primarily these are clinical areas. We then, of course, go through our commissioning, monitoring and final report process. All the time, though, we keep in mind the last column, which is the customer for that research. Every stage we ask, what would the customers want of this research funding? Very rarely are we sold down a line of this is beautiful science or a wonderful contribution to knowledge, unless we have a customer such as patients and the public, the Department of Health. NICE is a really important policy customer for us, the National Screening Committee, who will actually do something with these results. I talked about the fact that we put a lot of these suggestions to panels of experts. What criteria do we ask them to think about? Well, again, it's very heuristic. but we asked them to think about the benefits in terms of the reduced uncertainty. For example, what outcomes might be achieved for patients and carers. How long before the benefits could be realised, bearing in mind the time needed not just to produce the research, but also to bring about the change in practice. Would it offer value for money? There's plenty of important questions that just aren't value for money to answer in a research context. How important is assessment today, or should we be putting our mind to something else? And of course other factors which might have a bearing on the importance, so we can bring in ideas around national priorities or policy considerations. A big one for us over the last few years similarly has been dementia research. I'm going to talk through these, so don't worry about not being able to read the text on the left hand side. Where do we get these topics from? Well, it's multi-sources. The top box is our open form. So we have a form on our website that anyone can make suggestions to, and we get about 50 suggestions a year from that. The James Lynn Priority Setting Partnerships, we get about 60 a year. It's growing. Literature scanning, that's where my team go out and look at the literature across health research, and we cream that for potential research recommendations. We have our own journals library that all our research publishes in, that has research recommendations. The next one down at about 120, 130, are those panels, those expert panels, as well as prioritising the research. We ask them for ideas and we put those back through the system. NICE research recommendations. We have a very mature process of working with NICE, our key policy customer, on their research recommendations coming out of their advisory groups. Our staff within our teams and within the NIHR can put suggestions in. They get no special treatment. They go through the same system as anyone else. We get over 150 of those. We do a huge amount of widespread consultation. I'm now onto the bottom two bars. So over 350 topics a year, suggestions for research a year, come through widespread consultation. So events, stakeholder events, meetings that we run with patients, public, experts from the service. And the bottom bar, about 380 a year, is from Cochrane. So we will take all the research recommendations from Cochrane. So you might ask, why, if we get so much from widespread consultation and Cochrane, do we bother with the rest? We might just cherry pick a couple of the others. The important point is that if you only look at one or a small number of sources, you will inevitably end up with a biased picture of what the priorities might be. So we have to work across all of these areas. So for example, it would be morally, democratically wrong, I believe, not to consider James Lynn Alliance priority setting partnership outputs. Not wrong in killer puppy wrong, but wrong in terms of not considering those outputs from a democratic and moral perspective, irrespective of whether they produce an awful lot of funded research for us. So the final part of the process I wanted to talk about was coming back to this idea that studies should be designed with review of, based on what's already known in the scientific evidence. And I'll give you an example here, and this may be where we're getting into killer puppy wrong territory. This is some analysis done by Lau in 1992 for an intervention, streptokinase, which is a clot-busting intervention for heart attacks, for acute myocardial infarction. On the left-hand side, we've got the forest plot of a number of studies. At the very top, these are in date order, 1959 to the very bottom, 1988. Any dot to the left of the central bar favours streptokinase, the treatment under test. Any dot to the right of that central bar, the line of one, favours the control. And you can see we just kept on funding these studies time and time again. On the right-hand side, what Lau did was to say, well, what would have happened if someone had done a systematic review before embarking on the next study? So this is a cumulative meta-analysis, and it's like having done a trial with all the preceding participants. And you can see very quickly we get to knowing the answer. And give ourselves a bit of a break. I would argue that we knew the answer by about 1976, when we'd put about 3,500 participants through these kind of studies. We went on to fund studies from 1976 until 1988. We put another 34,000 participants into studies. When we were randomising them, presumably in about 50% of the time, randomising them to a treatment, we should have known we should have known wasn't as good as the treatment under test streptokinase. More than that, of course, we denied this knowledge to the much larger patient population. And this wasn't of marginal effect. This was a thrombolytic treatment for myocardial infarction. So if there's one thing I would say you could do today, there's a network called the Evidence-Based Research Network, which has been set up, and one of the founding members, to look at this problem, because it's not straightforward. We can't insist on a Cochrane-style systematic review. It's not the right methodology for much of the research we fund, and it's not value for money when it's a funding decision you're trying to take, not a clinical decision point. So a network has been set up to try and address this problem, partly to raise the profile of this issue, but also to try to resolve some of the issues in considering this as part of the funding process. So I'd encourage you to have a look at that network on the website. So I was going to pause there on that broad area of characteristics and priority setting processes. Any questions or comments?
I can sort of go back over the section until now.
Yeah.
Your initial kite diagram showed the spread of research across etiology, underpinning,
Yeah.
etc. One of the things I find staggering about it, and it's not unique to the UK, is prevention, which seems to be accepted as being, a needed area of focus, and yet it's the narrowest point on the UK graphs, narrowest for the Irish as well, and I think probably internationally. I mean, if we're in the business of trying to identify obvious or evidence-based areas to go after, why is prevention so narrow?
I don't think I know the answer categorically. I think my interpretation is there's two problems. One is a cultural problem. If you're going to if you're funding health research, by far the largest players, certainly for us in health research funding, are the clinical community. The clinical community largely are focused on treating disease. So you're almost too far down the line when you're engaging in that kind of community. The second thing is it tends to be much more difficult and costly research. You think large population level prevention studies are much harder to fund, they're much harder to deliver, they take much larger amounts of money and therefore take much higher priorities. We're trying to address that within the NIHR, where we've created the Public Health Research Programme. So all parts of the NIHR will support research relevant to public health, but there's a particular gap in public health interventions delivered outside the conventional health service. So to kind of get away from that cultural problem of most people's business being about treating disease and think about the population as a whole. Is a relatively small amount of funding compared to the whole of the NIHR, but it's an important step, I think.
Can I ask, thank you for your talk, can I ask you for a related sort of question? Those two forest plots that you presented there, they present quite a stark story. Can I ask you just to reflect on why you think that actually happened, and perhaps what other cultural forces might be in operation that led to such a phenomenon?
So that was quite a historical picture, obviously. So that was 1959 onwards. Many of those studies were small, and so presumably many of them were not, certainly they weren't definitive, and they weren't published in widely recognised places. It also predated a lot of the evidence-based medicine movement, so in some sense it's an unfair test to put of historical data, but it does still go on, and it's about the we think it's about the incentives of the research community to fund that next study, to find that next interesting question, not irrespective of whether the research is already done, but because that work is not being done in terms of bringing it together. Often it's not clear until you do that cumulative meta-analysis. If you look at that forest plot, until you do the cumulative meta-analysis, you cannot answer that question, and that just hasn't been the culture. It's not been the culture of funders, It's often seen as too difficult, too timely. You can't do a review before you consider every piece of funding decision. But we can see that there are some examples where actually absolutely that should be the case.
Yeah. My question is probably not unrelated to Graham's question. I'm very curious, and I talked to you afterwards about the process that you go through to determine importance. And you did a slide there, and you set out particular bullet points. So I'm going to ask the question slightly differently than I might have, because Graham's already asked his question. Do you think in assessing importance, the timeliness of impact, how big of a factor is that? Because typically in Ireland, a culture has developed, certainly in the last number of years, where impact equates with short-termism, this was referred to earlier. I'm just wondering, in the process that you're going through, and if we go back to the question about preventative medicine, it is a much longer term type thing. Does it also perhaps suffer from that? So that's one part of the question. The other part is then, how do you, and I know you're working in an applied research context, but what's the dynamic there? Or have you done any analysis, even looking at maybe when things have come to fruition and things that have been selected? Or are they more short-term, long-term? Sorry.
That's okay. Yeah. So it is important to us. One of the things that we try to do is to ensure that we're identifying the enduring problems. So the most obvious example is, for me anyway, is some of our health services and delivery research, which is about the way in which health services are designed and delivered, experienced by patients. In a broader sense of quality. We get a lot of suggestions, which are obviously very timely challenges of the service. They're about particular organisational constructs at the time. So at the time in the UK where the health service was being reformed, we had lots of questions about the change in organisational context, but we knew they weren't enduring. There might be an interesting question there around how do you cope with changes in organisational context and still kind of keep the wheels on the road, if you like. But certainly it wasn't an enduring question for us. Things around the change between primary care trusts and clinical commissioning groups as an example. So we wouldn't have considered those kind of questions much further. So we do look for those enduring questions. The second point is that one of the things that where we have heard this challenge from the service, which says, all very well, but we do need to know the answer to some of these questions in 6 months' time, in a year's time, in 2 years' time. What are you for if you're not for answering our priorities? Remember I said that that's why we were set up in the first place. We've got to listen to that. There are some things research just can't answer. Certainly in those kind of timelines. You need to find some other solution to it, and we're not the solution to all of the problems in the system. What we should do, though, is look at our processes and whether we can run those in order to take some of that waste out of the system to speed things up. So, for example, one of the things we've done is we've set up, ordinarily what we do is we identify priorities for research, we put them out to the community, they apply to us, we assess them. That whole process takes a couple of years. So it takes about a year to identify and prioritise the priority in the first place, and about a year to assess the research and get it going, get it started, go through ethics and those kind of things. So we created standing research teams where we could put those really pressing questions to them very, very quickly. So we cut out that year it takes us to identify and prioritise and commission the research. And of course you only do that for certain things, because otherwise you may start to bias your agenda. But if you've got a really pressing, important policy question that needs answering quickly, there is no point putting that through a year process of seeing whether that's important. The minister's told you it's important, they want the answer. And so we can put that to standing committees now to do the research. There are some things we can do, but we've also got to get across the message. There are some things research just can't solve the problem for. I'll run on to the last bit if you like. So this was just I wasn't going to give you much more information about the James Lind Alliance. Really, it's just to give us the opportunity to raise in discussion. We had a bit about this already, and it went into preparing your paper. The key points about the James Lind Alliance is it's a really powerful way of addressing this first pillar, particularly around involving clinicians and patients. Now, This wording is Ian and Paul's wording from the original paper. Again, we would set it more broadly, and James Lind Alliance would set it as broad, slightly more broadly in terms of clinicians, patients and carers. Two important characteristics around the James Lind Alliance. Firstly, it's an equal partnership between patients, carers and clinicians. It's not about asking patients their view. It's not about giving them a proposal and say, what do you think of that? It's about bringing those groups together in a room in equal partnership to have a discussion about what the priorities are. The second point is it's a very well-defined methodology. And so it should be reproducible. These things obviously, when they're quite qualitative, rarely are. But at least we know the methodology that we're following. And in doing that, one of the key points about that is that these are discussions where you're wanting to have research priority discussions with people who are not from the research community. So you need to structure the questions and have the discussions in a different way. Give you an example. You don't get much mileage in going to patients or clinicians and saying, what are the most important research uncertainties or clinical uncertainties that could be addressed by research? It's just not their language set, it's not their world. But if you ask questions like, of a clinician, what are the treatment pathway, what are the patients you see where you are unsure what the correct treatment is, or you're aware that your colleagues would prescribe a different treatment path, or if you're a patient and you're talking to your community, are you aware of situations where your treatment has been different from another's? Because they may start to indicate where there's some underlying uncertainty. It's just another example of where you get a different set of questions out. This was some analysis done for James Lind around patients suffering with knee pain. And again, you see this, the blue bar in the middle is what the research community, dominated by industry, but also the wider research community, spends most of its time doing, and that's investigating and running trials on pharmaceutical interventions. Actually, if you ask patients, they rate this only marginally more important to them than complementary therapy. Actually, what they'd much rather have is research on knee replacement, education and advice. So by having the right conversation with the right groups, you get a different set of priorities, and that's what the James Lind Alliance Priority Setting Partnerships were set up to do. Again, I'm going to supply these slides, so don't read them now. The idea is just to give you the range of completed partnerships. So they are very disease specific. That gives us a challenge. How do you run these kind of processes away from disease specific areas? And secondly, the current partnerships, the fact that it's growing. So this definitely seems to have some momentum in terms of a way of setting priorities, both within the UK in terms of growing numbers of price setting partnerships, but also internationally. So to finish this talk on the importance of the patient and public perspective in setting research priorities, I wanted to quote my wife, who asked me to say, completely ignore everything that her husband has told you today and put all your money in finding a cure for man. Thank you. Yeah, of course. Yeah.
We have a few minutes if there's any further questions anyone would like to put to Matt, or indeed any comments anybody would like to make more generally, even throwing back to the session this morning. We're almost bang on here. Yeah, just here at this table here.
Matt, thanks. Very enjoyable presentation. Could you talk a little bit about consensus building? Particularly, I guess the UK research scene is very large, and some of those areas that you mentioned there are thousands of patients, thousands of researchers, perhaps even in some of the areas. How do you bring people along? How do you get people singing from the same hymn sheet and agreeing that these things are actually priorities rather than imposing them? And does democracy work?
I think, excuse me, our approach is to break it down. It helps being a general research funder. So we are agnostic in many ways around the area of research. We certainly would not overly prioritise one particular disease area above another in a much broader sense. So, for example, the NIHR doesn't have a research strategy which says, and the most important thing for us over the next 10 years is X, Y, or Z. What that allows us to do is, in some ways, to dodge that issue, because it allows us to focus on many areas and do relative prioritisation within those areas, because all of these areas are important, of course, at some level. Once we've done that, once we've identified the number of different areas, it's about getting the right people involved in framing those research questions and then telling us which ones are the most important. So by letting it kind of boil down to quite narrow areas, I think we can kind of get away from that problem. But it does help being a large funder and a general funder as well, that we don't have to say, actually, we're going to put all our money for the next 10 years into cancer or dementia or whatever it might be. We might shine lights in those areas, but if you actually look back at what we've funded, we do quite a lot of analysis, for example, comparing what we've funded to DALYs, so burdens of disease and disability life years. And we see a fairly even spread across those things. What we're really interested in is that if you're going to fund research in cancer, what are the important unanswered questions? Where is the market not going to answer those questions if we just left it on its own?
Keynote Harry, Trinity College Dublin. My question or my comment is related to just what has come beforehand. I'm intrigued by the lack of reference to an overall ethical or moral framework, and in your presentation, and also it's reflected in the guidelines here. I mean, there's a comment here. There can be ethical issues related to priority setting. I think that reflects most of our concept of what ethics and research have to do with. It's to do with the ethics of a specific research project and whether collecting data or carrying out a procedure fits in with ethical guidelines. But what are your thoughts on, as I say, the broader ethical framework by which we come to the decisions as a society as to how we prioritise and where we prioritise? And whether is there a value in bringing that to a higher prominence, or is that just too difficult?
So one of the distinctions in the UK system is that the questions around service provision and the ethical implications of those, the social value implications of those, are delivered by NICE and others like NICE. So NICE and the National Screening Committee will have processes and discussions around what does society value in terms of service provision. So issues around kind of allocative efficiency or technical efficiency. Should we fund within our health service according to the overall greatest number of quality life years we can increase, or should we focus on important issues? Thankfully, we don't have to do a lot of those kind of considerations. It is others' decisions. What we need to focus on is what research do organisations like NICE need in order to answer the questions given their determination of those ethical and social value questions. Again, it helps us being a general funder. So we really do not need to choose specifically between different areas. We need to keep an eye on the balance, and we will look at how our portfolio is balanced, and we'll say it looks like we're not funding enough in musculoskeletal disease, or we're funding too much in cancer when you've got Cancer Research UK, those kind of things. And we'll look at balancing those across, but it becomes a relative priority question for us once you're inside each of those areas. Of course, the ethics of research is really important, and there is a whole system and set of processes and legislation in the UK to look after ethics of research within the health service and more broadly. And particularly in recent years, the Health Research Authority has taken on particular leadership in ensuring that this is considered.
Charles Norman from Trinity. I was just interested in how you select those who select. What are the criteria you use for working out who should be on panels, and because we all know that if you can get the right team, you can get the right answer. Yeah. I'm also interested in how you counter the sort of megaphone diplomacy that comes from particular interest groups in this process. Yeah.
So firstly, it's our starting point is it's open and transparent. So for all of our either our pool of expert reviewers or our standing committees, it's all open recruitment through advert. And then there's a selection process once people have applied. And there's some of the issues that we will talk through with potential applicants. The importance of the role that they have on the panel or the committee, what it is and what it isn't, the importance of understanding distinctions between kind of advocacy and representation. And what we're really interested in is lived experience and perspective, or expert experience, not people coming together and kind of arguing for their own particular area of research. It helps that being such a large funder, we can chunk those things up. So we don't have surgeons sitting in a room with public health practitioners arguing about whether we should be putting more money into surgical research or into public health. We have enough process and money to sort of split those guys up, if you like, and again ask them relative priorities within their own fields.
Mary Forrest from Manchester. Thank you very much indeed. Just in looking at your organisation, where you have, they often say people who generate the data, who analyse the data and who act on the data are different. And that's where maybe knowledge brokers come in, connecting people. Do you employ knowledge brokers, or do you develop the training and build the capacity of knowledge brokers, or are you acting as a kind of a global knowledge broker yourselves?
So two aspects come to mind there. One is that we do see ourselves in terms of the research funding programs as the broker between two communities, the research community and the research using community. That is the difficult job we do, actually, is to maintain that balance and sort of translate across those boundaries. The second area, though, is that the NIHR does fund a lot of knowledge brokers within the service, if you like, either through the research it funds, but particularly in a group of organisations called the CLARCs, which are the Clinical Leadership in Health Research collaboratives, and these are co-funded by the NIHR and the Health Service, and they're intended to sit on that boundary between research and the service need, and they have a number of terms for them, but in effect knowledge broker roles across those pieces.
Hi, thanks. I really enjoyed your slide about the meta-analysis, and it kind of comes back to the question about, as part of research prioritization questions about what research we need, we also need to ask about what research we don't need.
Exactly.
And to give you an example, in one of the experiences where we went through a prioritization exercise, two of the members of our panel subsequently published a paper about exactly what the opposite of what the prioritization exercise was about. So I'm wondering, has there been any maybe time or occasion where NIHR had to actually address those specific questions about what research we don't need? I mean, obviously we don't want unpublished studies, or we don't want studies that reach irregular endpoints, but has there been any case of that before?
Sorry,
has there been any case within the NIHR where you had to actually categorically state which research you were not funding, and research which had been funded previously?
Yes, we do. So in our both in our themed calls and our targeted commission calls, we'll quite often say, and we are not interested in X, Y, and Z. Usually the reason we'll determine that is because we think it's well covered, or it's just not in the spirit of the way the priority was articulated. Sometimes when we're talking about a health technology assessment, it's really easy to tightly specify the research question you want to answer. You lay out the population group, the intervention, the comparator, the outcome. But for much of the research we fund, it's not that straightforward to tie it down. So what you're really giving to the community is an idea of the type of research you want, and it can be quite easily misinterpreted. So quite often, particularly for those broader areas, we'll say, and we don't mean X. So we might, for example, say we're interested in diseases of the skin, but not cancer, because we know that those particular questions are covered elsewhere.
Okay. Oh, sorry.
Sorry, just a very quick kind of technical question for you, Matt, actually. I'm just wondering, in when you're prioritising the areas that you're interested in, do you also ask your panels to consider how best to deliver that funding? What kind of mechanisms might get you the best response or return? In
terms of the way the research is delivered? Yes. Yeah, exactly. It's one of those questions around the feasibility of the research. So we're very lucky in the UK that we have the Clinical Research Network infrastructure, which is a large amount of funding going into supporting research teams within the health service, and we can get quite a lot of intelligence from them. But particularly the committee, where we can ask the clinicians, the GPs, the surgeons, whoever it might be, is this research feasible? Is this going to work in your... Given that what we're funding are pragmatic trials, these are trials delivered in the health service, in the day-to-day running of the health service, they've got to be feasible in that context. And quite often, the answer will be, you're not going to be able to deliver this research. You'll never recruit the patients. The clinicians just won't have time to go through these processes. You've got to rethink the research methodology.